Thanks for coming. So this presentation and competency was kind of started by a meeting that we had just talking about that we maybe needed more evidence-based practice for our patients who have had lower extremity amputations. So I hope you all signed in and grabbed the competency. There's the actual competency sheet and then the quiz that will get you your credit. So do you all have that? Good to go? Okay. All right. So just starting off with a few statistics. As everyone knows, diabetes is the leading cause of lower extremity amputations. In the United States in 2002, so a little bit of some old data here, but 105,000 lower extremity amputations were performed. Over half were because of diabetes. In 2009, the number of diabetes-related amputations was 68,000. And in the United States, there are approximately 1.7 million people living with limb loss, and that's 1 out of every 200 people, so quite a few. So the level of amputation in 2003, the rate was 3.9 out of 1,000 people under the age of 65, and then that number just keeps going up. 6.6 ages 65 to 74, and 7.9 out of 1,000 people age 75 and older. We got some data from St. Mary's Hospital here that in 2 years, 2011 and 2012, that 57 total above knee and below knee amputations were performed. So 34 below knee and 23 above knee. So the objectives of our group here were to promote more consistency among therapists with the evaluation and treatment of these patients, and improve patient education with standardized written material to provide them, and improve patient care by increasing our treatment times, which we'll get to later, improve our positioning with staff and patient education, and promote evidence-based practice. So we will be going through these different areas for evaluation. We kind of picked out just some additional evaluation things that we may be doing with these patients. Otherwise, everything else, is what we standardly do with these patients. So one area is phantom limb pain using the visual analog scale. Making sure that we're asking a description of the pain to determine if it is phantom limb pain or surgical pain. Asking if it was present prior to the amputation. A lot of times the phantom limb pain will be basically the pain that was there prior. And then educating them on safety, just making sure that they're remembering that they had an amputation and not trying to get out of bed and stand and realizing that their leg is no longer there. We'll be talking about the amputee mobility predictor. Annika will be telling you about that. And then also Annika will be explaining some of the outcome measures and balance testing that can be done with this population.
All right, so to start off with the amputee mobility predictor, so this is basically an instrument that was designed to objectively assess whether or not a patient's, objectively assess a patient's ability to ambulate with a prosthesis. And they're tasks that you do prior to the prosthetic fitting, and just gives you an idea of whether or not they're going to be ambulatory after. And then some examples of some of the tasks that you do with them is transferring from one chair to another, standing with arms folded across your chest, and then standing reach, kind of balance stuff. And it's been shown to have high inter and intra-rater reliability. And we do have an example of it if you're curious, but it is something that we might not use here, but just so you guys know that it's out there. And then when going through the research, these are some other things that have been examined with people who have had amputations. They're common outcome measures. So the first one is the 2-minute walk test. So some statistics on there is the standard error of measurement is 48.5 feet. So that means, the standard area of measurement is the extent to which an observed score, scores are dispersed around the true score. So like what kind of variability there is with what you find. And then the minimal detectable change is how much change is a true change, and that's 112 feet, 112 and a half feet. And then it's found to have good retest reliability, and then high inter and intra-rater reliability. Another one that we know is the timed up and go, and they found that greater than or equal to 19 seconds indicates an increased risk of falls. And the sensitivity and specificity is there. And then the other one is a 4-square step test. And I don't know if you're familiar with that, but it's where you put 2 single-point canes crossed on the ground, and then you have them do a pattern of stepping from one to the next over the canes. And you actually are supposed to use canes and not tape on the ground, because they actually have to be able to pick up their foot and step. So with that, you probably are wondering, these are all been tested on people who are farther out and not in the acute care setting. You can go for it.
Over on one leg.
No, that's what I was saying now. So what we ran into is that, of course, as usual, there isn't much done in the acute care setting when it comes to examining this. So all these 3 tests are for people who have a prosthetic and are farther out, and actually were below knee amputations. So here, like I said, these are all functional tests that are feasible to do here, but like I said, they're farther out as a chronic, these are not acute amputations that were studied. And then they're also transtibular BKA amputations. So you might want to keep in mind for patients who come in like long-term that have been ambulating with a prosthetic, that it might be something that you can incorporate into your treatment plan.
Okay, we'll move into the PT treatment. So one thing that we came about was we were talking with some of the things that we want to do as far as increased patient education, staff education, that considering moving a patient to a BID treatment would be beneficial. Of course, this isn't going to be for everyone. A lot of times our patients who have had the lower extremity amputations are too frail and just not able to tolerate BID treatments. But the hope is that for those who are, we can incorporate this so that we're really covering everything that we need to with these patients as far as education and the exercises and mobility training. So we'll go through each of these sections separately that you can see up here and talk about each one. And the first one is patient education.
Sorry.
That's okay. So a few things that we are going to do differently, that we're proposing to do differently, and we're providing 3 Southwest and 5 East with all of this information in the file drawers so that it can be easily accessible by us, is to provide each patient with the booklet from the Rehab Institute of Chicago for below knee and above knee. They're excellent books, very informative, and have some great information for the patients. So those will be stocked in the 3 South and Southwest and 5 East clinics, and provide each patient with a written home exercise program. And Annika developed it on Exercise Pro, and it's in the protocol section. So we'll also have handouts though, so it's just grab out of the file cabinet and to give out. So, but if you ever needed to access it, it is in Exercise Pro. So provide each patient with a written home exercise program, and provide each patient with positioning guidelines to be posted above the bed so that the patient has access to it, as well as the nursing staff.
So
yeah.
The positioning guidelines, are those in the?
Yes, those will be in there as well. Those will be in the file cabinets as well. So already printed up for you, so just have to grab it.
There are exercises in that booklet too.
Yes, there are. Yep, and some of them are the same, as the ones that will be on the sheets. So the goal of the patient education is really to give control back to the patient and make them feel like they're in control of their situation and of their rehab. All right, so positioning. For below knee and above knee, and as I said, these are handouts that are in the file cabinets, 3 Southwest and 5 East. So below knee, some of the things just mainly as a review for us, but might be something new for nursing staff, which we're hoping to educate along the way here, and we're also going to provide them, the nursing directors, with a packet of this information to give to their staff and to have available to their staff to look over, so that they're aware of when they see this hanging above the patient's bed, they know what we're talking about. So below knee, keep the knee straight, avoid putting pillows under the residual limb, keep the legs close together, and don't rotate legs outward to prevent any flexion contractures or contractures in the hip adductors and abductors. Spend time laying flat on your back, or on your stomach, excuse me, for 30 minutes twice a day. Not all of our patients are going to be able to tolerate this, very few probably. So an alternative would be to have them lie flat in bed on their backs. Sitting in the wheelchair, sit evenly on both hips, keep the residual limb straight, and avoid crossing the legs. Above knee, similar as far as keeping the legs straight, no pillows, keep legs close together, don't rotate the legs outward. Same thing, if they can be on their stomach, great. If not, try and have them lay flat in bed for 30 minutes twice a day. And avoid sitting for long periods of time. Okay, so as we said, the exercise protocols are located in the file cabinets, and if we run out or you're on a different floor and need something, you can go to Exercise Pro and go to the protocols tab, and this walks you through how to find it, just as you would to find any protocol that's on Exercise Pro. Only use the print ones. Don't click Make Protocol, because that can change and delete what's on there, so just a reminder. The exercises that will be included in the below knee amputation exercises are listed here. I won't go through each one. We all know what they are, but along the way, if you guys do have any questions or suggestions for something different, please let us know, or finding that something's just not working. But this is a long list, so obviously you can pick and choose which ones, but this basically incorporates everything that we would want to be doing with a patient to get them ready for prosthetic wear or function, sitting in a wheelchair, things like that. So, yeah.
Is there a specific reason why you want to do glutes that's prone versus supine?
I don't know. Was there,
No, there's not really a specific reason. Yeah, you can do it in supine. It was just more to promote the hip flexor stretch if they can't get it. So I think that was the reason for the. Okay. If they can't do it supine.
All right, so then the above knee, same thing. We won't go through all of them. I think some of the differences maybe of what we've been doing historically is in adding some trunk rotation, as well as some abdominal strengthening exercises. Just kind of addressing the body as a whole, not just the specific amputation area. So.
So moving on to the mobility and gait training, same kind of process we do with pretty much everybody, right? Sitting, balance, sitting activities. Are they able to come up to stand with a device or Encore or anything like that? If they can't, slide board transfers are a nice way to work on things, or even scooting in and out of a wheelchair. For some of the above knee, we've had it where you just push the chair up to the edge of the bed and see if they can kind of do a backward scoot. And then progressing to gait training as you're able. Some of, like Annika said, we have some people who come in who are, long-term amputees and have their prostheses there. As we're starting new amputees, just trying to stand in, and if they're younger and stronger, can they take some steps with a walker? This is kind of interesting. It's just the cost of ambulation. When you look at how much increase in energy expenditure you have for the above knee and below knee, it's pretty amazing. 30 to 60% for below knee. That's a lot. Above knee, 60 to 100%. So you can see why it's a big task. And I know my sister, who is a PT over at the VA, for these younger guys that are coming back from the war, they have some nice prosthetics coming out where they're actually motor assist for foot for knee, that she said that some of the challenge there is actually controlling the power of the prosthesis, that making people kind of having almost a vaulting gait. So you can see where, if you're a younger person, it's another 100% increase in your energy expenditure to walk with it above knee, where some of this new technology is going to be very helpful, which I'm sure in our setting we're really not going to see very much of.
Yeah, Jay?
Did you guys come across any research or data on where I worked at before I came here? All the surgeons would cast a patient with a pylon. They could start with her and walking right away.
We did, and we'll talk about that in a little bit.
Do that in the military all
Right. You see a lot of these younger traumatic amputations in facilities that do a lot of them, do what they call a rigid dressing immediately, and pylons, and some of them are removable rigid dressings, but it almost varies, like within the nation, like people from this area do this, and a lot of it, speaking to some of the surgeons here and with my sister and all these other people who do a lot more amputations, it's almost who you trained under and the group of people that you're working with. So for edema management, some basic things that we can be doing: gentle massage, elevation, positioning, and patient education in this. Really bringing your patient on board, giving them some locus of control. This is what you need to watch. This is what you need to do, especially for some of our younger folks who are cognitively intact. Phantom limb pain, kind of interesting. I read a fair amount of articles about this. Pretty much resembles the pain experienced prior. The rates are fairly high. I was surprised at how big this number was. 50 to 85% of amputees experience it. Some simple approaches that we can start here. Again, some massage, tapping, trying to desensitize the area, towels, cotton balls. Obviously we don't want people like tapping over a fresh wound, but to not be afraid to touch their leg, to work above it, just kind of get used to handling it. I've read a few articles around mirror therapy, which is very interesting. Being studied for the treatment of phantom limb pain and fairly kind of chronic. These are people who are not acute. We'd expect some of this acutely. This is kind of down the line in rehab centers and people who might have been dealing with this for years. It's thought to use mirror neurons that are activated when observing movements and during mental practice of a motor task. The premotor cortex, they have like a mirror box where a person's sitting there with a mirror that's kind of running sagittally, and they're looking into it, and it reflects back, and it almost looks like that missing limb is there. And so then they can practice motions, movements, things like that, for people who have cramping pain, these types of things. Well, stretch your leg out, move your toes. And for some people it's been helpful. Obviously, I read a fair amount of studies. Nothing's conclusive. But Walter Reed is doing a pretty large study, and they're training people for 4 weeks and then doing MRIs to see before and after if they're seeing any changes in the brain with this kind of training. And some of the articles were interesting not only for amputation but also for post-stroke. A lot of hand stuff with some decent success. So the dressings, this is what started this whole conversation. When we're seeing a lot of our amputees, they're not being wrapped like how traditionally we were trained to ACE wrap everybody. In discussion with the vascular surgeons, and this is not just in our hospital and other hospitals when I've asked around, because most of our people here are vascular amputees, not traumatic. They are really worried about using the wrappings. If they're wrapped not correctly, then we're going to risk wound healing for those people. And in discussion with the prosthetist at Aljan's, I was saying, how are you seeing our people come from St. Mary's? We're not wrapping them. What's going on? And pretty much, he doesn't see it as an issue, and other prosthetists I asked don't as well. They use a shrinker for 1 to 2 weeks, only when the wound is totally healed. And he's like, from there it shapes quite nicely, and then they move on from there. So this is where the discussion of like pylons and rigid dressings and all that, because of the vascular issues that people here typically have, no surgeons do that. And we do have one younger guy now that I'm working with who actually is the first time I've seen a slightly rigid, it's almost kind of a cup on the bottom and like a brace behind his knee to keep his knee in extension. So that's the first one I've seen here that's had something a little bit different. And I think that was Dr. Scarpella that did that.
I see so many patients who walk in and they're all flexed up, the bandages falling.
Right, and that's part of what...
You know they're going to get contractures. Mm-hmm. Acid that would eliminate that.
Right, and some of the articles that I reviewed talked about using immobilizers, things like that. But here the wrapping, yeah, and then part of the discussion with the ACE wrap is, you know, really for it to be super effective, you know, for edema and shaping, you have to be doing it every couple hours, you have to be doing it very well. So, and that wasn't really, I don't think, happening. So they kind of saved the shaping for a later time. On to OT.
Excuse me. Well, for OT, the OT evaluation, it's not going to be a lot different than a regular evaluation. But what we came up with, assessing prior level of function, where they lived, how they were doing the ADLs, falls, DME, their pain level and pain location, upper extremity status, range of motion, any limitations that you see. With strength, also test, you know, in addition to the the manual muscle testing, the dynamometer for the grip and pinch, for 3-point or 2-point pinch. And the reason we felt that that would be important is just to look at, in the future, are these going to be people who can have a prosthesis? Can they manage pulling a prosthesis on, or is this going to be something that they're not going to be able to do because hand strength, hand control are poor? Coordination, doing like a 9-hole peg test as needed, again, to assess with the success that they would have with donning and doffing a prosthesis in the future. The current functional status with ADLs, feeding, hygiene, bathing, dressing, toileting, transfers, doing rolling and supine to sit, if able, in the evaluation. And then cognition, just doing functional cognition with maybe a short blessed or a slums, an Allen if needed. And then with OT treatment, we have upper extremity exercises. We have handouts made right now that have a varied exercises with TheraBand and hand weights. Right now they have packets made just together so every patient can have both exercise sets, so that if they're using TheraBand, let's say in the hospital, they can also have access to some exercises they could then do maybe at home with some free weights. Eventually, when we have approval from BJ Falk, she's reviewing some handouts that we have on coping and pain management, then everything is going to be stapled together so that every patient will then just get a packet and have all the exercises, the coping, and then the pain management all together. Treatment can do functional. Did you go away? Yeah. So these are all of the exercises, and then they're on the handouts. They are in Exercise Pro with an addition of armchair push-ups, which I couldn't find in Exercise Pro, but they're in the handouts. Okay. And then treatment can also include the ADL training, supine versus edge of bed versus chair, hygiene, bathing, dressing, and working with the patient to see what is the easiest for them. Functional transfers, rolling, supine to sit, in and out of the wheelchair or the bedside commode, chair, if they're able to do those things. Looking at falls prevention and safety, education, pain management, with the handout that we're providing, as well as coping with the handout, and then desensitization of the stump, as discussed earlier, and looking at activities for core strengthening, sitting edge of bed for ADLs and exercises, when you can, and if it's possible, standing for ADLs as able. And then I also have what we're going to have on 3 Southwest and 5 East are both going to have a copy of, we have a membership to the Amputee Coalition, and there's a magazine that's called In Motion that's really great. We're going to have one on 5 East, one on 3 Southwest, and we're going to just have it sort of in the file cabinet. You can just grab the most recent. If we start having a collection of them, maybe just giving them to patients, but maybe allowing patients to kind of take a look at the magazine, see if that's something, and they can join the Amputee Coalition for free and get magazines sent to their home. And we do have reference to the website, I believe, in the coping handout. So, and then I can also write it out maybe on the magazines as well when we get them. So.
And just to add a little bit from what Kami talked about, I did a little research on pain management and coping and came up with some patient education handouts, and we'll just kind of go over them. They're pretty straightforward. With the pain management, there's a little informational section on phantom limb pain and what that is, and it talks about pain often experienced after a lower extremity amputation beyond excisional pain is known as phantom limb pain. It's caused by a sensation in the brain and spinal cord that makes it feel as though pain is coming from the missing limb. And ways to manage pain include medications, which you would want to discuss with your doctor: ibuprofen, gabapentin, tricyclics, warmth therapy, keeping the amputated limb warm with warm blankets and a warm bath, and obviously the warm bath would be after the stump heals. Exercise your leg. PT exercises strengthens the limbs and can reduce phantom limb pain. Listen to relaxation tapes, visualization, and deep breathing exercises. Read a book or listen to music. Rub the leg gently above the amputated part to increase circulation, and possibly talk to an MD or your doctor about using a TENS unit. And with the coping handout, when a part of the body is lost, new amputees experience a grieving process that's not easy, and new amputees may experience feelings of depression accompanied by feelings of depression. And these signs of depression are lack of appetite, changes in eating problems, lack of energy, sleeplessness or sleeping more, poor concentration, loss of interest in enjoyable activities, loss of interest in sex, social withdrawal, feelings of hopelessness or inappropriate guilt, and flat emotions. And there's 3 different ways that people can cope: physical, emotional, and mental, spiritual. Physically, you want to make sure that you're getting proper rest, but you also want to stay active. You want to make sure that you get out of bed, get dressed, go out of the house. You want to eat healthy, not too many sweets, decrease alcohol. Exercise is very important, as we've reinforced here. Practice deep breathing. Emphasize your best features. Don't focus on the loss. Emotionally, you want to remember that you're not alone and that you're not to blame. You may want to journal feelings, increase contact with supportive friends and family. Communicate your feelings and needs clearly to family and friends. Explore meditation, guided imagery, and hypnotherapy. And then again, we have the Contact Us Support Group, which is the American Amputee Coalition of America, and we have that number and a website for that. Get professional help if depression becomes overwhelming, and know that these feelings will lessen over time. And then mentally, spiritually, commit yourself to work with medical staff even if you don't want to. Don't make big decisions when you're depressed, and seek professional mental health assistance when medications as needed. And some people may want to seek alternative medicine, massage, acupuncture, hypnotherapy, and always think positively about yourself and your body. And forgive yourself and do not judge.
Okay, so that brings us to the end. So in conclusion, we're hoping that everyone can think about for PT increasing therapy times to BID, just so that we can really cover everything that we need to cover. It's really hard in a half hour to do all this. So for those patients who can do it, increase to BID treatments, and then also provide the patients with all the handouts that we developed. We hopefully made it really streamlined and easy for everyone just to go pull these out of the file cabinet and give the patient a good reference to have, so including the exercise program, positioning, the book, the Rehab Institute of Chicago Rehab book, for OT, the coping handout, and pain management handout. So we'll take questions. Come on.
I was a little confused by the positioning recommendations, that not to prop up on a pillow, and then the recommendation to elevate. So how would I elevate someone if I'm up on a pillow?
Yeah, I think the pillow meaning right underneath the knee joint, promoting flexion. So, elevating with like the long way, so that the knee is straight on the pillows, just not a pillow underneath the actual knee joint. So that makes sense.
Yeah, not letting them.
Yeah.
Okay.
So even if they're in the wheelchair with some of the below knee, if we need to, you can use like even a slide board on their own prop.
I was wondering about that too, because you said when it's sitting, don't allow the knee flexion, and I didn't think that
Yeah, we had kind of looked into various attachments for wheelchairs, but nothing that really seemed useful or appropriate for us. So, in the past we have used, slide boards just on the leg rest and using that as a straightening board, basically. So, Sarah.
Just a thought, it's really important that you're getting that hip extension. So if you're going to elevate the leg, if it's a person who really needs the elevation for swelling, or they are just so uncomfortable with it down, then they should probably really focus on spending time being flat, intermittently throughout the day, because we don't want a hip flexion contracture, because then they're really going to have trouble with the prosthetic leg eventually. So.
Right. Yeah. I was going to say sideline. Make sure you work on sideline extension if they can't do the front.
Mm-hmm. Yep, that's a good point.
We also ordered a couple more sets of push-up blocks for folks that should be up on the east side, for slide board transfers, strengthening, all that.
Carrie, I have a question about the hip adduction. When I was in school a couple years ago, especially with an above-the-knee amp, we were always told not to encourage hip adduction, because with that shortened limb, you automatically go into adduction. So I always tried to keep the leg more in a neutral position versus, because your thing says together, and I would say more.
Yeah, I think, I mean, you absolutely you don't want to have the legs in an adducted position, so more of a neutral position, so that, that may be better terminology than having them together.
What you don't want is just them splayed over in the bed.
Yeah.
How soon afterwards can they get a prosthetic?
I don't know. I mean, I think it depends on wound healing and.
Weight bearing. But you said, in some places they'll amputate, do a flap, sew it up, and stick a pylon on.
optimal. So, but here, I think they're, all our ischemic folks, when I spoke to Aljams, they want that wound completely healed, and then they start worrying about prosthesis from there.
Question about prosthetics, and this may be beyond your guys' research, but I'm curious, like when we have the patients who come in who are, long-term, they've had a prosthetic leg for years, do you guys by any chance know what the recommendations are as far as how often they should have it checked? Because I feel like sometimes I have folks who have a poorly fitting socket with like a million socks, which is not good, but I don't know if there's like a recommended amount of time that they're supposed to have it updated and checked.
I don't know that there's, I don't know that I came across any like specific timeline.
Did the Aljams people say that they could check on them once a year? Yeah. Sarah, I thought,
was it from the insurance name? I don't remember what they said.
I think they asked them to follow up with them like on a yearly basis, not meaning that they would give them a new prosthesis. I don't know how many years. Anybody remember how many years that was? I think it was a pretty good stretch. Between like if they would buy them a new one, or there had to be enough changes in the limb or something.
I wonder, do we know if insurance would cover the checkups, just like the?
I did not. I don't know. I thought they talked about that when they were here.
So that they don't get reimbursed well, but they do it.
Okay.
Because it's what they should do.
Yeah.
I think so too, because not Algin, but people, wheelchair people will do that too. They'll come and they'll inspect your chair and make recommendations, and then they may help you get the medical clearance that you need to obtain that. It's not that Algin will come to do that.
So what is the consensus that we're supposed to do on the limb wrapping then? Since it's more of a concern.
Right.
Like you go walk in there and the ACE wrap is kind of.
Yeah, we haven't been seeing much ACE wrapping recently, so chances are you probably won't even have to, do that, but I guess if, I don't know,
we
if
fixed
there,
one yesterday.
Yeah, if there is, I would rewrap it if it's not looking like it's effective. Yeah.
Yeah, and then we have some nice handouts too that I'm sorry, I meant to have them so people can have as reference. But even when I was reading through all this stuff for trying to find, is there a dressing that was better than one versus the other, there is no evidence-based proof that one system is better than the other.
Yeah, each has their benefits and drawbacks to, to each one. So it's like we kind of talked about, it's where the surgeon was trained, what their preferences are, and typically here we're seeing no dressings right now, but I'm sure that's not 100%. So. Anything else?
Nice work.
So you guys can, hopefully there's about 15 minutes left if you want to just do your quizzes now and hand them in. They're hopefully not too hard, but give